Assalamu alaikum, I'm Dr. Junaid Jahangir Abbasi, and today we have a 3-month-old boy with us who presented initially with jaundice, abdominal distension, and discoloration of the skin. And he has been going through various tests. He has been going to different doctors, and the proper diagnosis was not made. And now, at the age of 3 months, we have a proper working diagnosis. Let's talk to the mother, and then I will show you the kid, and you will see what is going on, and what is our final diagnosis, and what is the management plan. अस्सलाम वालेकुम जी। तो आप ये बताएंगी कि शुरू में बच्चे को क्या हुआ था?
ये शुरू में ना इसका पेट स्वेल होना शुरू हो गया था और ये सोता ज़्यादा था, इसका कलर डार्क होता जा रहा था ना, जॉन्डिस था इसका।
जॉन्डिस भी था, ठीक है। तो पहली दफा इसका यरकान और पेट का जो सोजन है, ये कितनी उम्र में नोटिस किया था आपने?
15 से 20 दिन का था।
15 दिन का था तो इन्होंने नोटिस किया कि बच्चे को जॉन्डिस है, उसका पेट फूल रहा है। और अब तक जॉन्डिस चला जा रहा है या कम हुआ है?
नहीं, चला जा रहा है,
मुसलसल चला जा रहा है। और पेट भी जो सोजन है वो कम हुई है या उसी तरह है?
थोड़ी कम हुई थी, फिर वैसी हो जाती है।
अच्छा, थोड़ी सी सोजन कम हुई लेकिन फिर उसी तरह से हो गई है। When I examined this child, I found that the child is jaundiced. That if the camera can show the eyes of this child, he is jaundiced. He has abdominal distension. He has hepatosplenomegaly. Both the liver and the spleen are enlarged, and there is ascites as well. So, a 3-month-old boy having jaundice, hepatosplenomegaly with ascites. First of all, I did LFTs of this patient, and I found a direct hyperbilirubinemia with an increased gamma GT. So I thought that it might be a case of direct hyperbilirubinemia. Then I did an ultrasound, and the ultrasound revealed ascites as well as masses in the liver, and the liver was coarse. In short, the child was developing the features of CLD. So, having features of CLD at an age of 3 months was quite surprising for me. And that's why I've ordered an urinary organic acids and metabolic screening of this child. And the urinary organic acid screening revealed an increased excretion of succinyl acetone. You can see, if the camera can show you, the increased excretion of succinyl acetone in the urine. Along with this, the PT and APTT of the child were deranged, showing liver dysfunction, and FIPs were also being transfused. So, with features of liver disease in the form of jaundice, hepatosplenomegaly, ascites, and deranged clotting profile, and having increased succinyl acetone in the urine, I made a working diagnosis of Tyrosinemia, and the child has now been started on tyrosine-free milk along with nitisinone. We could not exactly confirm the enzymology due to lack of resources here in Pakistan, but the clinical picture and the increased excretion of succinyl acetone are pointing towards tyrosinemia. I have specifically asked the mother about the cabbage-like smell in the urine, but she did not notice any smell in the urine. Now, few words about tyrosinemia. Tyrosinemia type 1 actually results from a block in the catabolism of tyrosine, producing byproducts that damage the liver and kidney. So, it must be kept in mind that tyrosine is an amino acid which gets converted into fumarate and acetoacetate. This conversion of tyrosine into fumarate and acetoacetate has been done by fumarate acetoacetate enzyme normally in our body. Fumarate acetoacetate routinely breaks tyrosine into its breakdown products, but when it is deficient, the tyrosine will not be converted into its products. Rather, tyrosine will accumulate in the body and it will be converted into another product which is succinylacetone, and this succinylacetone is actually damaging for both liver and kidneys. Succinylacetone is the metabolite which is the damaging metabolite. So when we give nitisinone, what actually nitisinone does, that it blocks the conversion of tyrosine into succinylacetone. So even if we don't replace the actual enzyme which is fumarate acetoacetate, by giving nitisinone, we actually try to decrease the damage ongoing. Now it must be kept in mind that tyrosinemia is a metabolic disease, and like this child who is just 3 months old, it can present with early onset liver disease, with coagulopathy, and of course it can also lead to proximal renal tubulopathy. So if there is proximal renal tubulopathy, then we can expect edema in this patient as well, but currently you can see there is no edema. Overall, the growth is faltering as it's a chronic disease. Sometimes the rickets also develops in tyrosinemia. Secondary to renal Fanconi syndrome, the child may be developmentally delayed. However, in this case, there is a good neck holding, and apparently the development is not delayed till date. It must be kept in mind that the confirmatory test for tyrosinemia is liver enzymology, and in the liver enzymes, in the liver, we would like to see fumarate acetoacetate. This is the confirmatory enzyme test for tyrosinemia. And you can also do genetic testing, which is currently not available here in Rawalpindi, Islamabad. As far as the management is concerned, we need to restrict tyrosine in the diet. We need to give tyrosine-free formula and tyrosine-free and phenylalanine-free formula, and the ultimate treatment is liver transplantation. But liver transplantation is reserved for patients failing to respond to nitisinone. So we are currently giving nitisinone to this patient. Nitisinone is available in the form of tablets here in Pakistan. There is a risk of tumor also in these patients. So I had ordered an ultrasound of this patient just to screen the liver masses, and unfortunately the liver masses were present in the ultrasound. If the camera can show you the report of this ultrasound, you can see the conclusion which shows SOLs in the liver. So the surveillance of liver tumors is very important in these patients, and how we can do surveillance? By checking the alpha fetoprotein levels. So I have ordered an alpha fetoprotein levels, and you can see that the alpha fetoprotein level is raised in this patient. You can also screen liver tumor with the help of hepatic MRI. So it must be kept in mind that liver tumor and progressive chronic liver disease are the ultimate outcomes of this disease. And if the child is not responding to nitisinone, then we will be having no other option than liver transplant in this patient.